together and then make a new name. So hopefully after this lecture, you can figure out which one is which. So let's get started. So our first entity is deep angiomyxoma, aka aggressive angiomyxoma. So even from the name, we already know it should be, the location should be deep. And then there is another name is aggressive. So that means this patient maybe infiltrates into the tissue. And then we have angio, that means we have blood vessel, myxo, that is the myxoid stroma, and then forming a tumor. So the terminology already see it in the name, but I highlight here, this lesion should be hypocellular. And we usually find this lesion in vulva, vaginal, and pelvic area, and then usually in patient of reproductive age, and then had 30 to 40% risk of local destructive recurrence if incompleted excision. And from the growth sample, usually kind of big, more than 10 centimeter, poorly demarcated. So let's see this MRI. We can see this really deep mass, and then pushing the vagina. Then let's see the microscopic characteristic of this lesion. So as I mentioned, it should be hypocellular and then uniformly with infiltrative margin. And even the name say angiomyxoma, but for me it's more edematous. That means that this matrix is not that blue as other entity we will mention in today's lecture. Then another characteristic is this medial to large size vessel, and often with hyalinized wall. And one feature is really kind of unique for this entity, that is the smooth muscle, often close to the vessel. The buzzword is myoid bundle, and then mitosis is rare. So here we can see this medial to large size vessel, and then they have this characteristic nice thick wall. Then this is the tumor cell. They are small spindle stellate cell without significant atypia, so look really bland looking. Then this is the kind of specific feature for this entity, even though in other entity we also can see this. But when you see this, you should think of this diagnosis. So this is the vessel, and then adjacent to the vessel, we can see this small muscle always forming like vesicular growth, like lineage looking like this. And the immunostaining is Desmin, ERPR, HMGA2 positive. And usually this lesion is S100 and CD34 negative. So let's see some a virtual slide for this entity, aggressive angiomyxoma. So we can see this lesion, even in the ink border here, still touch the margin. So kind of infiltrated grow and really deep. And this is the epidermis of the skin. So even in low power, we can see kind of a low cellularity, hypocellular. Then when we zoom in, we can see some vessel, tons of vessel here. And the vessel have this hyalinized wall that is characteristic. And then this in this hypocellular area, we're trying to find that myoid bundle. Somewhat like this, the smooth muscle just forming like this vesicular growth. This sample is not as good as the textbook, but we can still see this. Another area, we can also see this characteristic kind of bigger vessel with this hyalinized blood vessel wall and this small muscle bundle. So let's see another one. As I mentioned before, even in low power, we know this is hypocellular. And then really edematous, not really myxoid looking, not really blue. And then big vessel with this hyalinized wall. And then this one is metal. We can see this small muscle bundle, we call the myoid bundle. And then really deep, you can see in the margin, the in margin, we can see this lesion not ended. Okay, let's continue. So the differential diagnosis I put here, we're going to talk about these three entities in today's lecture. And then for the desmoid fibromatosis, it's kind of easy to differentiate from this because this one, we have this spindle cell forming vesicular growth, and then we compare to this deep angiomyxoma, desmoid fibromatosis, kind of hypercellular. And then we have characteristic beta-catenin nuclear and cytoplasmic staining for this entity. So from the lecture, this one is not in this lecture, but I would like to put this because compared to the deep angiomyxoma, we should have superficial angiomyxoma, aka cutaneous myxoma. And for this one, less common in genital sites, and then usually small and superficial. We already know from the name cutaneous and superficial. And then characteristic is even in low power, we know this is not deep angiomyxoma because low power we will see vague lobula divided by fibrous septate. Then this one we can see through myxoid background because we can see blue. And then the vessel is thin wall vessel. You will not see this hyalinized vessel wall. And then I highlight here, I think for the exam's purpose, we always want to confirm this diagnosis, finding our friend neutrophil. And then this lesion also entrapped some benign epithelial elements. And then for the staining, it is also different from the deep angiomyxoma. This lesion usually CD34 positive, but ERPR negative. And we have a syndrome that is Carney complex. That is a PRKAR1A expression loss. So does anyone remember what is the specific location if we find this cutaneous myxoma and then kind of specific or usually common site for Carney complex? If we see some anatomy sites, there are three sites. One is in the nipple, the other one is in the eyelid, and then in the ear. These three locations more commonly seen in Carney complex. So let's see low power. As I mentioned, low power, you will know this is not deep angiomyxoma because kind of superficial, it always touch the epidermis. And then we have this vaguely lobular structure, and then separated by this hyalinized fibrotic septate, and then really hypocellular. Then we can see the small vessel, not hyalinized thick wall vessel, this thin wall vessel, and then kind of small. Then we will see neutrophil. Let's see over to slide. So here, low power, we already know we have this lobulated growth, nodule, and then separated by this fibrous septate. Then we can see this kind of like maybe epidermal inclusion cyst-like structure. So it also fit our characteristic. It always entraps some epithelial structure. Then from this low power, we also know that's really hypocellular. So if you would like to call something myxoma or superficial angiomyxoma, you cannot see hypercellular. And then also you could not see tons of blood vessel. If you see one of these two features, it's really not a cutaneous myxoma. So then we just zoom in to see this bland-looking spindle cell, but it's not the one I would like to show you here. I would like to show you what is this neutrophil. So as I mentioned, if low power is suspicious for this entity, high power, you want to see neutrophil. It's really characteristic for this entity. So, and then again, the stroma, you can see this is true myxosmal stroma because we can see this bluish. So all the area looks like the same, really hypocellular, and then the vessel wall is really thin. And then everywhere we can find this neutrophil. Another one look quite similar. Multinodular growth separated by this fibrous septate, hypocellular, and also not tons of blood vessel, and then entraps epithelial element, looks like a cyst. And we zoom in to see this bland-looking spindle cell, and then again we see our neutrophil again. So if you forget all of the stuff about this entity, remember this neutrophil, especially if you are not thinking about it. When you zoom in this hypocellular entity, you find neutrophil. Oh, you're thinking maybe this is cutaneous myxoma. Okay, the last one of this entity. Again, hypocellular, multiple lobule, nodular growth with fibrous septate, hypocellular. And zoom in again to see this thin wall vessel, bland-looking spindle cell. And then we see our neutrophil here. So this is good for cutaneous myxoma. Let's continue. Then we go to another entity, Angiomyofibroblastoma, AMFB. So this is a benign genital stromal tumor composed of fibroblasts oriented around prominent capillary vasculature. Occurs in women between 35 to 60 years old. And it also common sign is vulva and vagina. This is when it's slow growing. And then from the growth sample, it should be well circumscribed compared to the deep angiomyxoma kind of infiltrated border. And the microscopic feature is alternative zoom of cellularity. So that means in this lesion, you may see some hypercellularity area and hypocellular area, and then also prominent vascular components with red blood cell extravasation. And this entity called blastoma, I think, because they have this plump epithelial oval plasmacytoid cells, not as spindle as the entity we have seen before. And then the vessel also thin wall. You won't see this hyalinized capillary. And then for this one, for the myeloid bundle, that means the smooth muscle cell kind of forming this vesicle will be really prominent compared to other entity, even for the first one we mentioned, deep angiomyxoma. So you can see we have hypocellular area and also hypercellular area. And then even in this low power, you can see this vesicular growth, smooth muscle forming really long myeloid bundle for this entity. Then more classic features, just like in this hypocellular stroma area, we have this small capillary vessel. And then around this vessel, usually we grow this tumor cell more plump, spindly looking. They kind of aggregates, forming this kind of lobular looking. Then this is the high power feature to show this plump. Maybe the cytoplasm kind of spindle, but the nucleus kind of more plump, not like the previous you see. But the immunostaining kind of really similar to the like the angiomyxoma. Also, that's mean ERPR positive variable CD34, and then also this transfusion MTG1 CYP2E1 identified 10 out of 11. So maybe this one is really characteristic, but I think for the practical purposes, I don't think we have this fusion. Okay. Then we see this virtual slide. We've already seen this picture before. We have alternative cellularity. That means some area really hypocellular, and then some area we have tons of cells. Then I just wanted to show you this really characteristic myeloid bundle. You can see this one really catch your eye when you see this. Adjacent to blood vessel, we have this long vesicular growth. It's really long. So this one is really characteristic for this one, even better than the deep angiomyxoma. So for the hypercellular area, we can see this blood vessel and then all of these tumor cell, plump looking spindle cell, just aggregates in this hypercellular blood vessel area. Another one, even in this low power, we can see kind of like vesicular growth pattern. And then some hypocellular area and hypercellular area. And then zoom in, we can see this like small muscle just forming this long vesicle. That's it for this entity. So let's move to the other one. Oh, this one is really interesting because this is cellular angiofibroma. I would like to add off genital because in soft tissue part, as I know, at least 4 entities, we call it angiofibroma, and then all of them are not related. Anyone can say other angiomyxoma? What is the location of the other? Anyone have any idea? One location is from the face. That is from derm path, aka fibrous papule. That is the angiomyxoma. And then we have one from soft tissue. We call this angiofibroma of soft tissue. And then also we have one in the ENT. That's the nasopharyngeal angiofibroma. So all of these entities, I think histology looks different, but they all of them have the name angiofibroma. So for this entity, they have cellular in front of angiofibroma. And then the terminology for this one is a benign, moderately cellular genital stroma neoplasm composed of spindle cells and often contains small to medium-sized vessel with hyalinized wall. So for this entity, we have a lot of cells and then a lot of vessel, and this vessel is not big, small to medium size, and then they also have hyalinized thick wall, so just like the deep angiomyxoma. For the clinical picture of this entity, middle-aged to older adults, and it can occur in both female and male, usually well circumscribed, painless mass. So for the microscopic feature, as I mentioned, they have more cellular, hypercellularity of this lesion. They usually forming kind of like lobular or nodular looking, also separates by fibrous septate. And then the vessel is small to medium size, but they have hyalinized vessel wall. They may contain some of the mature fat tissue. So even low power is looked completely different from all the entity we already talked about today. They're forming this nodular, multilodular, and then separated by this fibrous hyalinized septate. And then even in low power, we know not a lot of stroma here. Most of this area are cell, so this is hypercellular. Then we have this medial to small size of vessel, but we can see this hyalinized vessel wall. And then the blend, and then the cell, spindle cell also blend. Rarely see mitotic figure. And then for the immunostaining, really characteristic, this is one of the entity we can see CD34 positive and loss of RB1. And then at least we have another 3 entity with the characteristic CD34 positive and loss of RB1. Anyone have any idea? What do you think about other 3 entities? I can tell you the location. One is from the breast. One is from soft tissue. One is from the acrocyte, that is the finger. Anyone can remember what kind of entity with this immunostaining feature? So from the breast, we have myofibroblastoma. Then from the acrocyte, we have SAF, superficial acrofibromyxoma. And then from soft tissue parts, that is the spindle cell lipoma or polymorphic lipoma. So all of these 4 entities, you will see CD34 positive and loss of RB1. Maybe they have the same pathognomonic. So let's see the virtual slide. So in low power, we can see this multi-nodule with really hypercellular looking. And then we zoom in, so tons of cells, these bland looking spindle cells. Then we try to find the vessel. This where, yeah, here we have tons of this hyalinized vessel wall vessel here. So, but the cellularity is really high, and then evenly distributed. You won't see just like AMFB. We can see hypocellular and hyper and hypocellular area. All the lesion like here is really hypercellular. Another one, multiple nodule separated by this fibrous septate. And then this one we can see entrap some adipocytes here. And then really hypercellular. Zoom in to see this vessel wall, really hyalinized thick wall vessel. And then lots of these bland looking spindle cells, but they all look like the same. And then cellularity is relatively high. Okay, so for this soft tissue part of GYN, we are done. And then we have this entity, vulvar intraepithelial neoplasm. So basically, the terminology, from my understanding, just like squamous cell carcinoma in the vulvar area, but they are kind of different because we divide this VIN lesion into HPV associated and HPV independent VIN. And in HPV independent VIN, we also separate them. One is P53 mutation, the other one is P53 wild type. And then for the clinical issue is that HPV-related lesion happen like in younger patients, usually in 40 to 50, and HPV-independent VIN happen in older age, like 70 to 80. In the growth picture, we can see this raised plaque with irregular border in this vulvar area. And then this lesion usually associated with lichen sclerosis. So we can see this reddish irregular border area should be in the background of lichen sclerosis. And then this raised plaque area should be our VIN neoplasm. So for the microscopic feature, I think this one just like what we see in the cervix area, the whole epidermis full of these atypical, pleomorphic, hypercellular neoplasmic cell. So this is HPV-associated VIN. And then we also can see some of these virus-infected coilocytes here. Again, this is also HPV-associated VIN. We can see really pleomorphic, hyperchromasia, and then mitotic active terms of mitotic figure here, and then the full thickness of atypia from the basal cell layer to the spinal cell, granular layers, so all the epidermis of the squamous epithelium evolved by this atypical cell. See this really big guys. Then we have another entity that is HPV independent, but P53 mutation. So for this entity, we only see this atypical hyperchromasia pleomorphic cell just located in the basal cell layer. You can see mitotic figure, really pleomorphic, like ugly looking cell. But other than that, in other layer, like the spinous layer, we can see this kind of eosinophilic cytoplasm, like this squamous cell just would like to mature, but not as pleomorphic and atypia as the basal cell layer. So this is a characteristic for the HPV-independent P53 mutation VIN. And then we also notice that in this papillary dermis, we can see really thickened collagen. So these lesions should arrive in this lichen sclerosis background. Then again, we can see this P53 mutant VIN HPV independent one. We also can see in the basal cell layer, really pleomorphic, hyperchromatic in the basal cell layer, all of these. And then other than that, we can see this maturing epithelial squamous cell, no atypia, no pleomorphism. And then this one also shows this acantholisis pattern. And then the last entity is HPV independent and P53 wild type. So this one, you could not see significant atypia, including in the basal cell layer. All the cell just maybe larger and with this eosinophilic cytoplasm. The only feature of this one is the epidermis kind of thicker. So this acanthosis looking. We also have this perikeratosis. Again, for this one, HPV independent, P53 wild type, we could not see any atypia even in the basal cell layer. All the cells look the same and then not really atypical. The feature we see just like thickening, hyperplasia of the epidermis. Even in high power, the cell looks not atypical. And then for this entity, I think from one of the grand one, we have the recording. I think one of the guest speaker from University of Virginia She has a really nice lecture about this VIN lesion. So if you're interested about this lesion, you can just go back to watch the video in our network. So for immunostaining, we all know if HPV related, we should have P16, strong, diffusely positive. And then we also have our P53 immunostaining. And then just bear in mind for this mutation pattern, we have overexpression. That means all of the neoplasmic cells